Whether you call them NOACs or DOACs, it really doesn't matter. It's new therapy, meaning new challenges, new issues, new controversies. So we're here to talk about them. And I am with Dr. Adam Cuker, who is an MD and also assistant professor of medicine and pathology and laboratory medicine at the University of Pennsylvania in Philadelphia. Now, coming from cardiology, I'm all familiar with these agents. You're kind of taking an interesting point of view with these drugs. Tell me about it.
Sure. So I think we've gotten good at understanding the efficacy and general safety of these drugs, but sort of we're now trying to learn more about them and what I call fine-tune the DOACs. And so some of the areas of fine-tuning that I'm especially interested in are how do we measure these drugs in the laboratory and how do we reverse them in cases where we need emergency reversal of the anticoagulant.
And we have a new agent just approved for dabigatran, so that now, and there's a new one I think for, is it rivaroxaban?
So yes. So this is a really exciting time for reversal. In October of this year, the FDA approved idarucizumab for the reversal of dabigatran, and there's another drug, andexanet alpha, which reverses rivaroxaban, apixaban, and edoxaban. That's a little farther back in development. My understanding is that the company plans to submit a licensing application to the FDA this month, and so I suspect that we'll hear more about that drug in 2016.
So in the field of oncology, what is it that you're doing?
Yeah, so I'm very interested in understanding better how to measure these drugs in the laboratory, for starters. So these drugs, unlike warfarin, don't require routine monitoring, but there are special situations where laboratory measurement may be indicated. For example, a patient comes into the emergency room on one of these drugs and needs emergency surgery. It would be awfully nice to know what the levels of drug are in the body at that time, and so I'm interested in assays that can be used to measure the drug in the body and determine whether it's safe for the patient to proceed to surgery. If the levels are too high and it's not safe to proceed to surgery, I'm very interested in strategies that can be used to quickly reverse the anticoagulant effect so that patient can get to the OR as safely and quickly as possible.
I mean, in oncology, this has been a little bit slower, partly because you've got patients who already have a disease. And where is it going in oncology? Where do you think in the next year or two some of these new agents are going to be used?
Yeah, so this is a really big, important question. So one of the diseases that I'm very interested in is venous thromboembolism. And a population of patients that are disproportionately affected by VTE are cancer patients. The standard of care for anticoagulation in patients with cancer who have a venous thromboembolism is low molecular weight heparin. We know that it improves outcomes compared with warfarin because they've been studied head-to-head in large randomized controlled trials. The problem is that patients don't like being on low molecular weight heparin very much because it requires daily or even twice daily injection, and they would strongly prefer, in many cases, an oral agent. And so now the question becomes, is it safe to use the DOACs, the direct oral anticoagulants in cancer patients? And so that's an area that's really important to study. There were a small percentage of cancer patients that were included in the large clinical trials comparing the DOACs versus warfarin for the treatment of venous thromboembolism. But there are a couple problems with those studies. One, the cancer patients tended to be maybe not reflect the usual cancer patient. Many of them had relatively mild forms of cancer. Some of them may have not even had active cancer at all. They may have had a history of cancer in the past and were in remission. So they may not reflect the patients with, for example, active metastatic cancer that we might see in the clinic. The other patient is that the problem is that the DOACs were being compared with warfarin. But as I mentioned, the standard of care in this group is low molecular weight heparin. So what we really need, and what we're going to have, is a randomized control trial of a DOACs versus low molecular weight heparin for the treatment of venous thromboembolism in patients with cancer. And I'm very excited to say that there is a trial like that is going on right now. It's recruiting quite quickly, I understand. I'm not directly involved in the trial. And I understood from one of the investigators that they hope to be able to present the results of that study at ASH 2016.
So what's the role today for these agents?
So they actually have quite a large role. So first of all four of the FDA-approved DOACs, so that's dabigatran, rivaroxaban, apixaban, and edoxaban, all of them are approved for two indications, and that is prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation, and the treatment and long-term prevention of venous thromboembolism. Two of the drugs, rivaroxaban and apixaban, have an additional indication, and that is for the prevention of venous thromboembolism after total hip or knee replacement.
Right. And so what do you think is going to be the next issue in terms of how are these going to be used in cancer?
So I think that the next big issue, I think, is we're going to try to address this question on two fronts. One is what we just talked about, a randomized control trial that really tells us how these agents compare with the current gold standard low molecular weight heparin. And I hope that we, again, have results on that soon. In the meantime, a lot of patients have already switched from a low molecular weight heparin to a DOAC because even though they may know that low molecular weight heparin is the preferred agent,
right.
They sometimes are willing to accept a DOAC even in an absence of strong evidence because they strongly dislike being on an injectable agent on an indefinite basis and prefer an oral agent. So I think another really important thing that we're doing in the field and others are doing is trying to get real world data on who are these patients that have made the switch, who are these cancer patients that are being treated with direct oral anticoagulants, and how are they faring on these drugs.
Do you have any good long-term data accumulation? In cardiology, we have tons of various registries. Do you have that ability to get those numbers over time?
I'm not sure. So, I'm familiar with like the Pinnacle registry that the American College of Cardiology has. To my knowledge, in hematology, there is no equivalent to that. Whether there is in oncology, I'm not sure because I don't practice oncology. Right. But I'm not to my knowledge. So.
But in terms of hematology, you need to come up with that because that's how we learn all kinds of stuff in cardiology.
Incredibly useful for real world data. This is what's going on in clinical practice. So you're absolutely right. Yeah.
And it makes perfect sense if the patients are told the data is over here with this drug, but this drug we don't have a lot of data, but it may be easier to take.
Yeah.
And the patient seems to want to go to that.
It's very appealing. I mean, a lot of the patients that are referred to me to talk about just this question, again, for them, quality of life is so very important, and they consider daily or twice daily injections to be diminish their quality of life, and so many of them are very enthusiastic, even with the caveats that I talked about of switching to an easier drug to take.
Well, the whole evolving issues of anticoagulation and hematology, it's a fascinating area. We've got a lot of it here online and from ASH 2015, where I'm Rick McGuire.